So let's go. Share. Anyway, as a start, welcome everybody. This is the first evening episode of our small animal medicine educational hub. So I think 2025, new year. We've done a bit of a Chris, are you still holding your hand up? Because I've asked you if you could hear me, or do you have no? Perfect. I've asked you guys for a little bit of feedback on what the best timing would be for our presentations, and you came back with me in the evening. So let's try and do that. The other thing that I got in 2025 is a new oncology course will start next month, and I am working on the other survey that we've done online, which was to start a community and thinking about ideas, what we can put in there so that it would be helpful. If you got any, get in touch. I'm open for plenty of things to try, probably one at a time, but we'll go from there. So again, welcome everybody. 14th of January 2025 today. So we will have a short free CPD where we're going to discuss feline intestinal masses. And it is a broad overview. Obviously, in 20, 30 minutes, we can't fit everything in. But let's talk about how you could try and differentiate or work these ones up and give you a big overview of treatment options there, really. So, I mean, if we're talking intestinal masses, I definitely see my fair share of feline intestinal masses. And they're not highly common in practice, but I'm sure you all see them on a fairly regular basis. So the incidence is about 4 in 1,000 cats a year. And if we look at what is more common, as a lot of these tumors, it doesn't matter where they are in cats, generally lymphomas are your most common presentation, followed by adenocarcinomas. Now in dogs, third one would be leiomyomas or leiomyosarcomas, so the soft tissue sarcomas, which we only very rarely see in cats, really. And as a third group there, we are talking about mast cell tumors. So if we look at how these cats present, I mean, overall, when these cats present, they will be presenting with GI signs, so not eating very well or completely stopped eating, vomiting, and that frequency can depend a little bit if there is partial obstruction or complete obstruction potentially, diarrhea, which might have some fresh blood in it or some melena, and these signs are going on chronically, so they are gradually getting worse. And sometimes it's hard to figure it out, and you're going to have to ask your owner specific questions. And one of the questions I quite like, rather than saying, where did it all start? I tend to ask them, when was your cat in this occasion last normal? When do you think your cat was last normal? Because that will often take them further back to the first time the cat vomited or the cat stopped eating, just to get a bit of a timeline there, really. And as with many of those neoplastic diseases, signs are chronic, but they're also slowly progressive. So that often gives you a key, what are we looking at, really? Now, as these cats are not eating properly, they'll be losing weight. They'll be quieter, probably a little bit because of abdominal pain there as well. And they might have some blood in their stool. So on your examination, you often will find these are often older patients, but that are quite skinny, unkept coat. They might be extremely cachexic if it's been going on for that much longer, taking into account that a lot of these cats are very good at hiding what they do, or if it's a multi-cat household, other cats might be eating and it might not be noticed, or they might be toileting outside. In the vast majority of these cats, we will be able to feel a palpable mass, okay? Reason for that is they are very skinny, so there's very little cat surrounding the mass. And because these problems are more chronic, the mass is often a fair size. So I think that is something you can feel. And then sometimes, but definitely not always, there is some free abdominal fluid there, which you might be able to sample, and it might give you an indication there. So no real surprises on the presentation. Now, if we look at the labs that we get with these cats, these are older animals. I mean, we could have a dehydrated animal, so some pre-renal azotemia might be present. As these are older cats, it could be renal as well. Often they might have some anemia, either of chronic disease or because of chronic blood loss, so iron deficiency there really. Very commonly, very mildly raised alk phos is present, and is not necessarily meaning that the liver is involved. And because of the blood loss, they might have, and they're not eating, a slightly low protein level. And then the not eating will drive some hyperkalemia as well, which you kind of hopefully want to correct if you're going to anesthetize these animals to do, or sedate them to do further investigations. So, I mean, and then the second step often is going to be, and where we're going to try and find an answer, is we're going to hopefully do some imaging. So radiographs are very rarely done in these animals, and I think definitely plain radiographs, you will often see a soft tissue mass if it's a fair size, but it can be often it's mid-abdominal, hard to say where it's coming from. Okay. If you've got bowel obstruction, then the proximal intestine will be dilated, and you might get some ascites where you're going to have some loss of contrast there, really. Now, I mean, not going to say in the good old days, but say, and very rarely, I can't remember the days that we used to do this. Now we have ultrasound available, but contrast radiographs will often give you a good outline of what's going on, and you'll get this almost what they call an apple core effect if it's circumferential, but obviously a complete narrowing where the contrast goes through. These days, I mean, my preferred way of investigating these animals is doing an ultrasound. An ultrasound will give us a very good overview of where the mass is, often will allow us to say, is this a lymph node, which is not uncommon? Is this an intestinal mass? But depending really how obstructive it is, because it can be hard to find an intestinal lumen there, really. So, or to follow these intestines through. Oh, and as everything is really compressed together, it might be a little bit difficult there to see if you're not highly experienced. But ultrasound will allow us to have a good look at the area. And what it allows us to do as well is go and sample these masses. So there's almost no reason, bar coagulopathies, really, that there's no reason to not go and aspirate these masses. Now, not to go completely through cytology, but lymphoma often exfoliate very well. So does an adenocarcinoma and a mast cell tumor. We'll go through them in a little bit. But mast cell tumors, definitely these feline mast cell tumors, might not be as typically well granulated as the canine cutaneous forms often are. So they might well need special stains to recognize them. Adenocarcinomas, you'll get little clumps or sheets of cells. And then with lymphoma, you generally, as long as you get a viable sample and you haven't crushed all your lymphocytes, you will get an answer on what is going on. Sarcomas are often a little bit harder to exfoliate. But again, as we said, they're the vast minority of these. So aspirating them gives you a good indication there, really. Now, the other thing on ultrasound, what we'll often see, we'll either look at more, are we talking, is this a circumferential mass? Is this entailing the whole circumference of your intestine? Is there any loss of layering, which is very, very common for tumors, but very uncommon for inflammation, unless you have very severe inflammation there, really. And then what we're going to look for as well are these lymph nodes enlarged. And it's not unusual for them to be slightly larger. But when we talk about mesenteric lymph node, we often say thickness clinically 3-4 millimeters. As a reactive change, definitely possible 5-6 millimeters. But if we're talking lymphoma, we often will find these into 1 centimeter, 2 centimeter, 3 centimeter lymph nodes, really. So although we don't often do CT, there is a recent paper on CT findings if you end up doing CT, because I think ultrasound is very much something that if you have somebody that has good expertise in that will help you. A CT will probably give you less details than an ultrasound for a small animal like a cat, but definitely with the contrast, you can get some indications. So what they found in this paper, where they try to differentiate lymphomas from adenocarcinomas, was very much that when they gave them contrast and the top three pictures here is a cat with an intestinal adenocarcinoma. The bottom three is a cat with lymphoma. Okay, so when they gave them contrast, and this is the early pro-contrast phase, you can see that in the center, the mucosa really gets an enhancement, and the periphery surrounding it is enhancing as well. And that is what you see in the late contrast phase as well. In lymphoma, you don't really get any of that mucosal enhancement that you can see, or the peripheral enhancement. So they found that that was quite a significant difference between these patients. They found that although the carcinoma patients, some of them had lymph node enlargement, it wasn't as fast as some of the lymphoma patients they were. And when in the patients they looked at, they found that the carcinomas were more obstructive or more likely to be obstructive. None of their lymphomas were obstructive. Now, take into account these are retrospective studies, and I think there were about 10 lymphoma patients in there, or maybe 11, and about 6 carcinoma patients, so they're not massive. What they found as well is that the thickness of the intestinal wall was generally thicker in cases of lymphoma than in adenocarcinoma. And again, although these are none of them are specific findings for either one tumor, it can help you to give you an indication. So if we then split them up, I mean, the main one to talk about really is lymphoma, because we know more than half of these animals that have intestinal masses are lymphoma patients. Now, I'm sure you all know when we talk about lymphoma, most of the talk goes about, is this a small cell lymphoma or is this a large cell lymphoma? Small cell intestinal lymphoma is also called a low grade or alimentary lymphoma. The high grade lymphoma is the large cell or the lymphoblastic lymphoma. So there's different names in circulation, really. But if you think about it, the small cell lymphocytes are the closest to a normal lymphocyte, a normal white lymphocyte that you should find in your blood if there's nothing going on. So these are small cells. They're about the size of a neutrophil. And they're the normal resting lymphocytes. So it's a less abnormal disease, if you think of it in an abstract manner. Therefore, it's slowly progressive, and they generally don't give masses. They generally give the diffuse muscularis thickening and the more chronic signs of weight loss, inaptance, some diarrhea there. But it's more generalized or more diffuse thickening. When you get masses, you're almost certain that that is not going to be a small cell lymphoma. You still need to diagnose this because it could still be a different tumor, but we're talking intermediate or high-grade lymphomas. They often present in these ways, and these are only 2 examples really. But you get a complete transmural thickening, which often compared to some of the other tumors is quite hypoechoic in nature. Okay, it's going often the whole way around it, although it might be more leaning towards one side than the other side, and you get a loss of layering, which you don't often have in the small cell lymphoma. You might get some ulceration with some shadowing, and as we said, commonly your lymph nodes are going to be enlarged as well. Now, the third group, which are quite an uncommon type of lymphoma, is what we call the large granular lymphocytic or lymphocyte lymphoma. And again, if you look at the presentation, so this is a table with all 3 on there. I mean, these are all the cats. Often these days, these cats are FELV negative, but we'll always check them. And when we look at focal intestinal masses here, focal intestinal masses, the low grade one is in the middle. And although it could have slightly enlarged lymph nodes, it's very rare for it to have a significant intestinal mass, really. Treatment and prognosis completely different. The low-grade lymphoma is a slowly progressive one. We're talking about oral treatment. We're talking these cats do very well. And average remission time is 18 months, 24 months, or even longer. If you look at a difference between high-grade lymphomas, the ones that respond, and we see a response probably in about 40, I would say 40, I mean, 80% is quite high. I wouldn't say we see that. Probably 40 to 60% has a complete response rate. And we're talking for an average response time of about 4 to 6 months, leading therefore to a survival time of 7 to 10 months. Now, if you look at the depressing figures with your large granular lymphocytic lymphoma, is the same treatment protocol that they're using, but we're talking complete remission rate is 5%. And the ones that go in complete remission, and that's with a COP protocol, that's the only study out there for the moment, we're talking 2.5 weeks. So these are not good cases, really. So let's go to the second more common one there, adenocarcinomas. So again, adenocarcinomas, I mean, the presentation is often very similar as our lymphomas there, really. We still have common lymphadenopathy, although it's often not that large. And often, although I've written here hyperechoic, there can be mixed echogenicity that we can see, really. When we look at the studies and how these carcinomas then are staged, if you go and look for them, we know that regional metastasis, we're talking lymph nodes, we're talking liver, we're talking mesentery, that is very common if you start sampling these animals. So we're talking the vast majority, we're going to find some spread here. We're talking as well that lung metastasis on X-rays are pretty uncommon at the time of diagnosis. But I wanted to run this study past you because it always used to be taught that if you find metastatic disease, there's no point going for surgery. I think that has definitely now, this study points out that that is not what the feeling is out there anymore. So we're looking at these cats that have been treated with surgery or without surgery, and the cats without surgery have an average survival time of about 4 weeks. The cats with surgery in this study, and some of them had metastasis and some of them don't, but are very much, their average survival time is a year. Okay, so there's a vast significant difference. This is what we call a Kaplan-Meier curve, and it looks at your survival probability. So your median one is at 0.5. As a general rule, and I'm not saying that always is the case, but if these lines are completely separated, then you most likely have a significant difference. If they overlap or crossover, you most likely don't have a significant difference between the two. So now if we split these patients up, I mean, what else did they look at in that population of cats, really? And again, the 18 cats, so it's not hundreds of them. But they looked at, does it matter if we get a complete surgical margin? And that did seem to influence, really. I don't have the graph on here, but one cat had surgery but had incomplete margins and only survived for 2 months. The other 9 cats that had complete margins on histology, their survival on average was 3.5 years. Okay, so there's a huge difference of doing a solid surgery in the first place. And the current advice, really, when people looked at a different study and they looked at the intestinal masses and how far from the mass did you get clear, no tumor present in the margins, the current advice would be if you can, you take 4 centimeter each way from what you can feel. Okay. Although 2/3 of the tumors that they removed had a tumor-free margin at a 1 centimeter. Okay. But still, as many of these things, as with mast cell tumors and soft tissue sarcomas, if you can do a wider surgery and it's not going to complicate matters more if this is small intestine and you take 2 centimeter either way or 4 centimeter either way, you give that patient a lot better chance on the long term if you can get a clear margin, really. Now, interestingly, even with these patients that then had a proper surgery, their survival time was not significantly different if they had metastatic disease at presentation or not. Okay, so the ones that did not have metastatic disease at presentation, it was 2.3 years. The ones that did have metastatic disease was 1 year. Now, take into account, I mean, there's a bit of overlap here, so it wasn't significant either on the calculation, but that might well be because there wasn't enough patients in the study. Okay, so to compare them, the less patients you have, the bigger difference has to be, and the less overlap there to find that there's a significant difference. So, I mean, the ones without metastatic disease still on average live twice as long. Okay, mast cell tumors. Now, these are not very common at all, but they're the third most common um, source of intestinal masses. And most often they will present as focal masses. Sometimes, very rarely, they can be multiple masses throughout the GI tract, or they can have more diffuse GI thickening. So just diffuse GI thickening is not automatically a small cell lymphoma or an IBD. It could be a mast cell tumor as well. We still have loss of layering, and most often we find these mast cell tumors in the distal small intestine or the large intestine. Metastases are common. Again, liver, spleen, lymph nodes is where generally mast cell tumors will go to. None of the patients in this study had lung metastasis. And we know that ultrasound appearance, both for canine and feline mast cell tumor disease in the liver or the spleen, is not a sensitive way of finding them. So it is quite possible that these patients, their liver and spleen on appearance looks normal, but aspirate is the right way forward there, really. So diagnosis, as with all of these, FNA or histology, if your FNA didn't give you an answer. And although all the studies gave these cats a very poor prognosis with median survival time of about 2 months, we now find that in these latest study, we found an average survival time of about 1.5 years, and some cats doing better. I think I'm just going to go to the next slide. Yeah. So in this population of cats, they had some cats, and again, this is a retrospective study. There's some cats in the solid line, which is down here, which were all still alive at the time of loss to follow-up about 500 days. That surgery and steroids. We have some cats that surgery, steroids, and chemotherapy. Okay, the dotted line. We had some cats that did not have surgery and had chemotherapy. And then we have some cats that just had steroids. Okay. And this is this bottom line here. Now, as you can see from what I said earlier, I mean, these cross over fairly regularly. So on this study, didn't find a survival difference in the cats that received chemotherapy, the cats that had surgery or not had surgery, and what type of treatment they had. Obviously, the numbers again are not massive, but what you can't say is if you would have treated one cat that had steroids on their own, one cat that had surgery and steroids, if you treat them with chemo, would they have done better? I guess that's impossible to say, really. But overall, what it does say is it's well worth treating these cats. This is far better for all of these than 2 months, really. And what we know as well is that the cat with the masses in the large intestine, if they survive surgery, because colonic surgery and the immediate post-surgical phase, that they do better than the cats that had a small intestinal mass, although that is easier to resect in theory. So we mentioned stromal tumors. So stromal tumors, I mean, is a version where previously we were talking leiomyomas, leiomyosarcomas, and definitely in dogs. We know now that we can differentiate those from what we call just gastrointestinal stromal tumors, and we see those in cats as well. So if you get a soft tissue sarcoma in the intestines and the stomach, in dogs and in cats, and often now the histology report will suggest that you check for this, but it's worth checking for c-KIT really in a way that if you have a mutated c-KIT, then these are often called GIST tumors, and these are the tumors as well that on a recurrence can respond to tyrosine kinase inhibitors. We know as well that you need a very wide resection for these and possibly up to 6 centimeters each way. And then the last bit I want to talk about is one of the things that does give masses and that we're starting to recognize maybe slightly more, but is non-neoplastic. Okay, so we're talking, and this is a long-term feline GI eosinophilic sclerosing fibroplasia. So this will give discrete masses, often in the intestinal tract and the lymph nodes, but it's always been reported as well in the retroperitoneal space and even in the retropharyngeal lymph nodes in some cats. Okay, if it is within the intestinal tract, you often find it around or near the ileocolic junction or the pylorus, so not easy places to go and resect. And you do need histopathology to try and diagnose this, but they are challenging to diagnose. And it is something, I mean, you often, obviously, the eosinophilic part, the fibroplasia, but these are things that you might have to have a chat with your pathologist about if you're suspicious of this, and raise their awareness. Now, in some of the studies, there's definitely a proportion of biopsies that have come back with bacteria. One has been fungal or parasitic organisms in it. So the idea is very much that this is an aberrant response to these organisms in some of these cases. So if you want to know a bit more about it, so this is mainly disease in middle-aged cats, and some reports have a predisposition for male cats. Okay. Now, about a quarter of the cats in all the studies are ragdolls, but also other pedigree cats. So pedigrees are more than half of the population that's been reported. Okay, so there's a minority of domestic short hair or long hair cats in here. What we find is that these cats present with very much chronic signs and very similar signs as what we just discussed in the other masses. So palpable mass, pretty much always there, chronic vomiting, diarrhea, not eating very well, leading to weight loss. But about 15% of these cats has a fever. Now, if you look at the bloods, eosinophilia is present in about half of the cases. Often they have some anemia, a low albumin because of the GI loss potentially, and the acute negative phase protein. And often they'll have a raised or top end of normal globulin. These cats, compared with the other ones, which we haven't necessarily mentioned, but definitely with the lymphomas, we often see a low cobalamin. These cats often have a normal cobalamin. Okay. And most cats only have one mass, although they could have, in theory, multiple. Now, the appearance that we see on ultrasound is obviously still often a loss of layering or abnormal layering, but you often have more this heterogeneous appearance compared to what I've showed you with the adenocarcinomas or the lymphomas. It's this more irregular appearance that you might find. Now, how do we manage these? I mean, you can go and remove them if they're in a site that is removable, but that on its own does not appear to cure this patient. It does in the initial phase, but often these cats will relapse a few months, a few years later with another mass of the same pathogenesis. So, and in the recent studies, they found that surgical resection actually does not give you a surgical or a survival advantage, really. Corticosteroids often will improve survival, and we start these on an immunosuppressive dose of corticosteroids if we know that there's not an infection related. And then we tend to taper these slowly off. And in some cats, we might need a second immunosuppressive agent. If you find infection, obviously we use antibiotics. So if it was a fungal infection, which was in the States, not here, then antifungal treatment. And interestingly, in one study where people looked at adding these cats that are already on steroids on a hydrolyzed diet, about 40% of the owners thought that their cats were doing better. But again, this is a retrospective study, and these cats are already on steroids. So, I mean, we need to get more information about the hydrolyzed diet. But overall, the survival of these cats is very well if we can manage them. This is a medical disease and not necessarily a surgical disease. So I think that's all I had to say about the intestinal masses in cats as a quick overview. There's obviously an awful lot more to say and protocols and things to go through, but that takes an awful lot longer. So that is not for in this talk. What we're going to go through, hopefully in 2 weeks' time for whoever's here, is just raised liver enzymes. We'll talk about the different ones. What does it mean and when should we worry, and what patterns can we see that would suggest one disease more than another one, really? I'm just going to put this slide up. So for the people that are interested in oncology, if you want to know a bit more in-depth information, we're going to do the first 4 modules of plans on round cell tumors that we're going to talk about, and they're very much structured around recorded teaching almost, so you can do that at your own timing, and then we will do weekly discussions or Q&A sessions that we can talk through. I'm going to try and keep it to small groups if we can, because I think if there's too big a group, people don't necessarily speak up or ask any questions. But if anybody wants to know more, either, I mean, it's on LinkedIn, send me an email, however you want to. And this should be starting beginning February.